at our institution, what we learned from some of the previous work that we did was that urine toxicology testing on labor and delivery was being sent pretty much by clinical discretion. So physicians were sort of deciding arbitrarily this patient may need a urine tox screen and this patient may not. Now, most of the time it was some sort of, based on some kind of a hypothesis, like maybe this patient's at high risk based on their amount of prenatal care or some kind of remote history. But it was really hard to understand what the reasons were. And because we know there's such adverse downstream consequences to having positive urine tox screens, we wanted to find a way to sort of systemically be able to screen. So that was the rationale for the study. Now, what we did is we implemented a universal sort of standardized screening protocol for whom we would be able to send urine tox screens on. And it's sort of elaborate. It involves sort of an iPad-based screening tool what the patient is filling out. It's being imported directly into the medical record, and then based on a few specific criteria that would trigger a urine tox screen to be sent. Most importantly, we base that criteria on evidence, on what we know are true reasons why a patient might be at risk of having a positive screen, and on rationales that would actually inform clinical decision making. And that way, we're sort of avoiding some of these traps of testing the same populations over and over again based on their demographics or their race. So we implemented this over a couple of months and it required a lot of nursing education, staff education. And what we found was that before we implemented this screening tool, that we were testing people of color, so Black patients, Hispanic patients, disproportionately more than their white counterparts, even though there's no evidence that substance use is higher in those populations. Once we implemented this process, we found that those disparities went down. So that was really kind of the main finding of our study. So that's a really good question. As a part of our initial study, we weren't unable to see what happened next. So in terms of social work consultations and I guess, yeah, downstream consequences for the baby. What I will say is one of the major findings of our study was that the overall number of urine toxicology screens went down. So we found that after we implemented this, fewer people were being tested, by urine drug testing. So I think it wouldn't be inconceivable to think that probably the referrals to social work and to, child protective services went down. I don't think that would be a totally I think that would be realistic to think that something like that would have happened. And the same goes for neonatal testing. Now, we have a whole protocol also for what happens with the neonate based on what happens with the mom. And then, of course, there's going to be scenarios where mom wasn't tested or maybe even tested negative, but the baby may have signs or symptoms of withdrawal or something, and then that may trigger another workup. So those are all things that we actually really want to look at. It's important to know that, you know, even if we look at all patients that have positive urine tox screens, what the literature suggests is that even amongst them, there seems to be more punitive consequences through child protective services and so on and so forth in people of color. So, we can do a lot of this work on the clinical side, but sort of what happens once it gets handed off to CPS and so on and so forth is a little bit out of, what we can do in the healthcare system. But it's a really, I only mention it because there's clearly work to be done on a much larger scale than what we're just doing in the hospital. One of the most important changes that we made when we implemented the screening protocol was that we actually removed marijuana from our urine drug screens. So in the pre-implementation period, if you look at all the positive urine tox tests, the most commonly reported substance was marijuana. Now, marijuana is a legal substance in California. Drug testing, again, it doesn't tell us anything about long-term use. It doesn't tell us about whether or not necessarily, the patient themselves has a substance use problem. And so after a lot of kind of coming together and thinking about this issue, we decided to remove it completely. So the fact that the urine tox screens actually didn't, the percentage of positive screens didn't change, actually just tells us that it was more efficient and more effective, right? So now we're actually picking up substances that may change clinical management, may affect sort of neonatal management because we removed a substance that probably doesn't matter as much.